All right. I just got back from talking to Grandma, and I tried to give her a bunch of information about what's going on right now, her procedure tomorrow, and what the future could look like. And I thought I would make this, hopefully, quick video to try and fill you guys in as well, so that we can all help her make the best decision going forward. So real quickly, we're dealing with heart failure, right, with her. So what is heart failure? You can see in a normal heart rate, you can imagine this is a patient laying on their back. This is the right side of the heart. This is the left side. This would be their right and left, not our right and left. But in a normal person, you get deoxygenated blood from the body into the right side of the heart. That blood is pumped by the right side of the heart to the lungs on both sides. That blood gets oxygen from the lungs. It comes back into the left side of the heart, and then this left side, when the heart beats and squeezes, that blood is shot out up the aorta, where it is distributed all throughout the body to all of your tissues and organs. Now, when somebody has heart failure, that output of blood from the heart to the body is diminished in some way. There can be, we'll talk about a couple of things that can cause that, but there are, heart failure can be mild, it can be moderate, it can be severe, and then depending on what's causing it, you can have a variety of symptoms. So for Grandma, the big symptoms that we're seeing right now is that you can imagine that if this heart is not moving blood the way it's supposed to, blood backs up. And when it's left-sided heart failure, blood backs up into the lungs. That's sort of what we're seeing with her. You can imagine when you have fluid in your lungs, obviously that's what causes shortness of breath, and that's what's caused her to need supplemental oxygen. And it can make you weak because you're not getting as much oxygen-rich blood to your body and to your organs and tissues as you're supposed to. So as far as what can cause congestive heart failure, a whole bunch of stuff: heart disease, blockages in the arteries. She doesn't have a history of that. High blood pressure can cause the heart muscle to become stiff and weak. Old age causes that as well. But mainly for her, the two things we're looking at are her atrial fibrillation and her newly discovered valve disease. So when you have atrial fibrillation, right, a normal heart, you have a built-in pacemaker in your heart. It sends electrical signals through the muscle of the heart, and that's what causes the heart to squeeze. It does this really regularly, and that regularity allows the heart to fill up, these chambers of the heart to fill up full, nice and full, and then when the heart squeezes, it doesn't send all of the blood out of this ventricle, but it sends a nice, good squeeze, a big volume of blood up the aorta and to the rest of the body. But you can imagine that you can see when you have AFib, essentially what's happening is in the upper part of the heart here, the signal is getting messed up, and instead of being nice and smooth throughout the muscle of the heart, you're getting all this erratic electrical activity throughout the upper part of the heart, and it causes your heart beat to be really irregular. Now you can imagine that when the beat is irregular, part of what's happening is that if beats come premature, while the heart is at a relaxed state and it's supposed to be filling up with blood, all of a sudden it gets this premature electrical impulse that causes it to squeeze, and so you have a chamber here that's not as full as it should be, squeezing from a heart that's already weak, and so not a whole lot of blood is getting up out of the aorta. Now if you have fluid in the lungs, and that you're already not getting as much oxygen in the blood as you should be, and then you're not filling the chamber the way you should be, and then the heart isn't squeezing as hard as it should be, you can see how all of those things contribute to less oxygen-rich blood being delivered to the body's organs and tissues. And that's why heart failure is bad, obviously. For her, she has the additional issue of valve disease. So this is the aortic valve. It lives between the left ventricle and the aorta here, and when the heart is relaxed, the valve is closed, and that's what allows that chamber to fill up nicely. Then when the heart squeezes, it opens up and allows blood to go up the aorta into the body. When you have disease, that valve can get real stiff and it doesn't move the way it's supposed to. So instead of opening nice and wide to let all this blood out, it doesn't. And then instead of closing and with a nice tight seal, it allows blood to leak out. So you have this blood that isn't getting the oxygen it's supposed to because the lungs are full of fluid. Then you're not filling this chamber as much as you're supposed to because of the AFib and because blood is leaking out of the aortic valve. And then you've got a weak heart that's not squeezing as hard as it should. So those are all the things seemingly in grandma's position right now that are contributing to her heart failure. Tomorrow she's going to get what's called a left-right heart cath with a dobutamine challenge. So what they're going to be doing is they're going to be measuring pressures in the right heart cath part. They're going to be measuring pressures all through the right half of the heart, if you will, to evaluate like how well her lungs are functioning. Then in the left heart portion of the procedure, not only are they going to be measuring pressures inside they're trying to determine how bad the valve disease actually is. So they're going to measure pressures in the valve and in the ventricle and in the aorta at the same time, and they'll use those numbers to get a gradient, and that'll allow them to determine how bad the valve disease actually is. So you can see here that exists on a spectrum as well, right? You can have a normal valve, you can have mild, moderate, severe disease. So this is what they're going to be trying to determine tomorrow. A big part of what they're going to determine tomorrow is how bad is that aortic valve disease that she has. Now, they mentioned already that she has a bicuspid valve, which means, let me go U of M. Instead of having 3 leaflets, she only has 2. I think that's just genetic. I don't know if that develops over time or not. But also they mentioned that she has a lot of calcium buildup. And so you can see, this is nasty, but how when that calcium builds up like at the base or around the leaflets, that's what causes them to be so stiff and not move as well. So they're going to get a better idea in tomorrow's exam of how bad this valve disease is. Thirdly, the dobutamine challenge part of the procedure is they're going to give her a medication called dobutamine, and that is it causes the heart to beat stronger, to squeeze harder, if you will. And they're going to take pressure measurements before they give the dobutamine and after, and they're going to see if that type of medication improves her numbers, essentially. So if it does, they'll know like, hey, she's a good candidate for these, certain types of prescription medications that can improve the strength of her heartbeat. So we'll essentially tomorrow get the sort of 3 outcomes we can get, right? So if they say that her valve disease is mild to mild moderate, they might just recommend, hey, the valve isn't that bad, it's not worth replacing, so we're just going to send you home on medication, assuming that she responds well to the dobutamine, and say, hey, live your life, you have valve disease, but it's not bad enough to be replaced, so here's this medication that is hopefully going to help you manage the symptoms of heart failure. If they determine that the valve is moderate to severe, then they're going to determine whether or not she's a candidate for a TAVR valve, which we'll talk about in a second. If she's not, they may say, hey, you have really severe disease, but you're not a candidate for this procedure. if they think that the risk is too high that she wouldn't make it through, and there's a variety of reasons for that, then they may just recommend go home on medication and just enjoy your life to the best of your ability, because that's kind of the best we can offer for you right now, because the risk of going through this procedure is just too high. If they determine that she has moderate to severe disease and she is a candidate, they will start talking about a TAVR, which stands for transcatheter aortic valve replacement. And so this is a TAVR valve. It's a mechanical valve. It has a ring. It's got this sort of metal meshwork that holds it open, and then inside that ring is a mechanical valve. Now, it also has a balloon. Part of how you deliver this, right, is you can see there's this delivery system. You go in through the groin here into the big artery there, and you put this catheter, this delivery system, all the way up the chest, down the aorta here, and across that aortic valve. And then once they get it in place, they inflate the balloon that's in there. It opens up this ring, pushes it real firmly up against the walls of the aorta, and then they hold it there for a couple of seconds. They deflate the balloon, and they pull this whole delivery system out, and what's left is this ring that has a mechanical valve inside that does the work of an aortic valve the way it's supposed to. It stays closed when the heart's filling, and then it opens up when the heart's pumping. Now, when it comes, so the procedure is pretty common at our lab. We do probably, I don't know, anywhere from 2 to 6 a week, and they have great outcomes if they're a good candidate for it, obviously. And so if they determine tomorrow that her valve is moderate to severe, and she, then she's going to meet with an interventional cardiologist. She'll meet with a cardiothoracic surgeon, and they'll go through all these risk factors to determine if she's a good candidate or not. And so that'll obviously determine whether or not, what decisions we have to make. They could decide that if these vessels aren't big enough, or they're too flimsy or too squiggly, and they can't safely deliver the device, then she might not be a candidate. If they think that her diabetes isn't managed well enough, or she's not mobile enough that she wouldn't do well in recovery, if they don't think that she has a good backup plan, if she's not a good surgical candidate, they might decide it's a little bit too risky, because if something goes bad and they had to repair it surgically, then it's just not worth the risk. Keep in mind that there's time to make that decision, right? If she was unstable now and she needed a TAVR valve emergently, that would be one thing. But she's stabilized now that the UTI has been treated, and so I think probably what they'll recommend is that regardless of their finding, they're going to say, hey, either your aortic valve is mild, moderate, or severe. Hopefully she responds well to dopamine, and they'll send her home and say, hey, try out life for a few weeks on this medication, see how your quality of life is. Hopefully she doesn't need supplemental oxygen. Hopefully she doesn't feel that much fatigue or short of breath when she's moving around, and maybe she decides, I don't need the surgery if she's a candidate, or the procedure, and maybe she just decides to live with medication, and there's nothing wrong with that. Maybe she bounces around for a couple of weeks and she says I hate carrying around this O2 tank. It makes her walker too heavy. She's too fatigued to move around the walker with the O2 tank on it. She gets short of breath, just trying to get up and move across the room. My quality of life is terrible, so I would be, willing to try out this procedure. So when it comes to the risk factors, there are many, but the procedure is overall pretty safe. Some of the risk factors include bleeding from the site. Obviously, you're putting a large device into this artery. You can have bleeding in worst case if you damage that artery bad enough and it shuts down flow to the rest of the leg. They would have to surgically cut into her leg and repair that artery. That is not common, but it's something they're going to bring up. Whenever you're inside the heart and there's all this buildup of calcium and plaque, you always run the risk of potentially dislodging some of that, having it go upstream up the aorta into the great vessels that lead to the brain, causing a stroke. Not common, but something they're going to bring up. Based on positioning the valve, you can see that these coronary arteries that feed the heart with blood are right there. And so if you damage the coronary arteries while placing the valve, that can be really dangerous. Again, not common. If they look at all of this anatomy ahead of time, and if they determine that there's risk of blocking those, then they take preventative steps to be able to open or repair those if things go wrong. Not common, but they're going to bring it up. I'm trying to think. More common issues would be electrical issues. So in order to keep, you can see right when the heart beats, I just closed it, but when the heart squeezes, it moves around a lot, right? So in order to place this valve very precisely, they will speed her heart rate up to like 180 with a temporary pacemaker wire. So rather than the heart like squeezing and relaxing and squeezing and moving around a lot, it just sort of kind of vibrates in place, and that allows them to place the valve more precisely. But pacemaking like that can cause electrical abnormalities. It can put people in heart block, and it can mess up the natural pacemaker of the heart, in which case she may end up needing an external pacemaker down the road. They may end up recommending that anyway because she has AFib. Not the worst thing in the world, but it would just be another procedure that she'd have to undergo. So something they'll bring up. I think those are kind of the big risk factors. None of them are particularly common. Like I said, we do quite a few of these a week and have great results. We've only had a couple of cases go bad, and generally when they go bad, it's not because of like mistakes that are made. It's just because the patient kind of doesn't have the constitution to, like, you can see when you're placing this valve and you're inflating that balloon, you're completely obstructing flow from the heart to the body, and sometimes people just aren't able to handle that very well, and so they just decompensate and their blood pressure drops and they need support. So all things to be made aware of, things that shouldn't be feared, but just need to be understood in case something were to go wrong if she does decide to go through the procedure. So yeah, tomorrow the big decisions, it'll all depend on the outcome of the right and left heart cath she gets tomorrow. I hope this helps everyone understand things a little bit better. If you have any questions, obviously feel free to ask me and I'll do my best to answer, and I'll be in touch. Love you guys.